Okay, thank you for some fantastic sessions there. We've got lots of questions that have come in for our speakers, so I'm going to get straight to it. And I'm going to start with Dr. Russek. During diaphragmatic breathing, some people experience lightheadedness and or an increase in dysautonomia symptoms. Is that normal for EDS patients, and how can we breathe without getting dizzy?
So a little bit of dizziness is common when we change our breathing habits, and it's often due to hyperventilating or overbreathing, breathing too much, and your body's not used to it. And so some of it will fade with practice. Some of it you can decrease if you breathe more slowly or not quite so deeply. For some people, it might actually help to breathe into a paper bag or even using a mask so that what causes the dizziness is actually not a lack of oxygen, but blowing off too much carbon dioxide. And so if you actually put your COVID mask on and breathe into that, that might actually help you as well. So some of the lightheadedness is normal and can pass with practice, but there are some strategies that you can use to decrease it by breathing more slowly, more gently until you get used to it, or even trying breathing into a mask so that your carbon dioxide levels don't go too low.
Brilliant, thank you. Now for Dr. Simmonds, and I'm not sure if everyone is also seeing what I'm seeing. Everyone looks a bit green with a green tinge on them. So apologies if there's any visual disturbances or if it's just on my end. So Dr. Simmonds, does the spider tool work for the rarer types of EDS?
Thanks very much, Lara, and thank you to the person that asked that question. The spider tool really has been developed with people with symptomatic hypermobility and hypermobile EDS in mind. As time goes on, we will look to validate the spider against the other forms of EDS as well. Those who have got other forms, you'll recognise that many of those symptoms, it's about the symptoms that you have, but it's not all of the symptoms that you have if you have some of the rarer types. So we would need to probably, add, maybe another leg or two on the spider to be able to incorporate those. So I think at this stage, this spider is being developed and validated for hypermobility spectrum disorders and for hypermobile EDS. It's looking very good. Our validation studies are coming through very strongly, and thank you to those people who have been doing the surveys. So I think you can use aspects of it if you've got the rarer type. But yeah, not for all the rare types at this point.
Thanks so much. And a question now for Jeannie. We're being asked if you could elaborate or explain dynamic stretching again. How does it differ, and is massage a form of static stretching?
Yeah, that's a great question. Stretching always comes up. So if you think of static stretching, as something that you go into a big stretch and then you hold it and you're kind of pushing yourself to that end of range. And the reason first, as I said in the presentations, research shows that static stretching doesn't really change your tissue in the long term. But the reason I don't like us to do it is because I think that people hang into those postures. So they hang in the joints while they're doing what they think is a stretch. So it's potentially very damaging. Dynamic stretching, on the other hand, say if you take a simple cat pose, which most of us probably know, where we're on all fours and we're going in and out of that flexed position, that is a form of dynamic stretching. So you're not pushing into your end of range, but you're gently teasing the tissue in and out of a movement. So you're getting the hydration and you're getting the gliding, but there's no potential for hanging. And I think the hanging is the dangerous part for us for injury. And what was the other bit? Massage, is that a static stretching?
Yes.
I wouldn't have called it that. I mean, I don't know if the others would have a comment on that, but I wouldn't have said it's a form of static stretching.
It depends on what you include in massage. If you were to include myofascial release, that often has some static stretching component.
Yeah, and I would avoid deep tissue massage. I think we were talking about that in the earlier presentations. You know, people often react quite badly to the deep tissue massages because it can destabilize the joint. And so people can often feel worse after having a deep tissue massage. But yeah, the myofascial release is wonderful. I think the gentle massage techniques are really, really good.
Can I just
Thank you.
Yeah, can
Please do. Yeah.
If that's okay. It's nice to be able to have a bit of discussion. I'm longing to be in the same room as everybody.
Wouldn't that be nice?
Just to add to what both Leslie and particularly what Jeannie was talking about with the dynamic stretching, it's really interesting that in performing arts and in athletics, the use of dynamic stretching has been shown to improve performance because it also activates the motor control. So it's actually a way of improving proprioception as well. So it activates and prepares for readiness. So in that respect, I think it's also got that aspect. I'm sure that's something that Jeannie's sort of, you know, is integrating into her movement therapies, because it's all about, you know, getting the activation and getting that motor control going.
And if I can add one more thing about the stretching, I think static stretching can be done safely. I think it is more risky because it does tend to allow people to hang on ligaments and joints, but people can be trained to do a stretch correctly and to stabilize those joints. So it's not that all static stretching I think is bad, it just has to be done correctly. And sometimes you need a professional to make sure that you're not stretching the wrong thing, because we always tend to stretch where we're already stretchiest, but that's not what we're trying to stretch. We're trying to stretch the stiff parts.
Thank you. And Dr. Russek, we'll stay with you if that's okay. So trying to see where we're up to. Are there any contraindications for physiotherapy in different types of EDS or comorbidities?
There are many contraindications for any individual person that physiotherapy done poorly can cause harm. So I think it really needs to be, the physiotherapy needs to be customized to the person, and it can be done safely, but what safely is will depend on the individual person. For some patients, I have to be super, super, super gentle and go more slowly. Some patients can do a bit more. So you can't generalize and say that all of physical therapy or physiotherapy is contraindicated. Everybody can do something. For example, the breathing, I think everybody can learn to breathe a little bit more efficiently. So it's not generally contraindicated for anybody, but there are a lot of things that some physiotherapists might do that might not be appropriate for a given individual.
Thank you. That's very helpful. Dr. Simmonds, what diets would you say are recommended for people with EDS or dysautonomia?
Look, I'm not a dietitian. I'm just going to put that out there now. So, you know, big disclaimer there. I'm not a dietitian. And so it wouldn't be my place to, you know, to talk specifically in that respect. I think in my presentation, I talked about that for many people, they find that the low FODMAP diets are helpful for some of the gastrointestinal problems that people have. People do find some low histamine diets helpful if they've got the problems with mast cells. The thing about the FODMAPs diet is that it has been well researched in people with IBS, irritable bowel, which has got some links, if you like, to some of the reasons why people have gut problems. It is, you know, it's a pretty safe diet. It is quite restrictive though, but I think one of the things that comes through over and over again, that often there are, you know, some foods which make it difficult for our digestion and put stress on it. In particular, and I got this tip from Professor Matthias and his specialism in POTS, is that actually having high carbohydrate diets and particularly lots of sugars are one of the reasons why people with POTS can often feel quite tired afterwards and often quite faint. And the reason for that, he explained, was when you have that kind of input, that you can have high, that you get a lot of insulin production, and that then acts as a vasodilator, which can actually make your blood pressure drop, actually make you feel quite faint. Plus, it can also make you feel tired as well. So often, you have to deal with diet quite carefully. Some people, there may be reasons why they have to have certain diets and other things. But I think generally speaking, reduce the carbs, don't overload the carbs. And often the FODMAP diet is, a good starting point for people.
Brilliant. That's great. Thank you for answering that. I know that's not your area of expertise, but I think that's really helpful. Jeannie, how can movement therapy help for those that are in bed or a wheelchair or without range of motion?
Yeah, it's a great question. I work with people who are bedbound right now and in wheelchairs. So I do have clients who are in these conditions and have obviously very limited range of motion. As I think the theme that is coming through in all our presentations is that there is always something. I'm a firm believer that it doesn't matter where you are today, there's always something we can do. And we start with the breathing, just like any other person. We start with the breathing, we start with the awareness, we start with the relaxation. And then very, very gently, very slowly, we start to open up their world a little bit, and we start to do little things that start to build that confidence and that self-belief that I was talking about in the presentation. So, please don't be disheartened if you are, wheelchair or bedbound. There's always something we can do, and we go at your pace. And if whoever you're working with, they understand that, they go at your pace, and little by little, small steps.
Brilliant. Thank you.
Can we chip in?
Yes, please do.
Jeannie, can we chip in as well? You're absolutely right. The breathing, the awareness, the relaxation, and that has come through very strongly. And, it was great to see people saying that, some of the things that they might do as their first step might be to start with some breathing. But, we mustn't forget the role of, just muscle activation. So just doing some gentle isometric work can get the muscles starting to become aware again. And isometric training, went off the radar for a long time. People wanted to everything moving, but actually isometrics have got a role to play. So gentle isometrics, can be a way to at least get the muscles woken up a little bit.
Can I just follow on from that? Coming on to the isometrics, that's a really good point, Jane, because I've been doing some experiments on pelvic stability with specific isometric exercises for these patients who have obviously not a lot of muscle conditioning around the legs and the pelvis. And they're reporting really, really fantastic results in how they feel much more stable around that area. So isometrics, definitely, they should definitely be utilized more.
Thank you. Thank you all. Dr. Russek, we've got quite a few questions that have come in around sleeping. So I'm going to try and combine them a little bit so we can get through quite a few of them. So one question is, and I've lost it now. Where's it gone? There it is. Do you have any tips for people who can't sleep in one position due to discomfort? And what are the best ways to support the body so that it holds together when people sleep? And the last part of the question is, are sleep studies beneficial? And if people do take them, are the ones at home accurate?
So it can be very tricky to find a comfortable position to sleep in. And I know that from my own personal experience, it takes months for me to find a comfortable position, a comfortable bed surface, and it changes over time. So what worked last year doesn't work this year. So finding a good bed surface that is enough support, but enough padding. You may need pillows. Some trial and error can be helpful to support different parts of your body so that you're not weighing yourself down into the mattress. But it can take some trial and error to get as comfortable as possible so that you don't have the need to toss and turn. But of course, some movement in bed is normal and natural. If you have struggled with trying to find a comfortable position and you haven't been able to, then consult a specialist, a physiotherapist, physical therapist, who might be able to help you and help you understand. It's like, oh, well, put a pillow under your waist so you don't have so much weight on your shoulder and your hip. I'm sorry, I forgot.
It was the sleep studies. Do you think they're beneficial, and are ones that people can do at home, are they accurate and reliable?
It depends on what you want to use the sleep study for. I think it's pretty well agreed upon that people who are hypermobile are the princess and the pea, and we don't sleep well, period. And you don't need a sleep study to tell you that. And so unless there's some specific problem they're looking for, like narcolepsy, it's pretty safe to assume you don't sleep well because you hurt and because you're uncomfortable. So just solve the problem. For people who have sleep apnea or think they may have sleep apnea, try sleeping on your side if you're not already, because that works for 50% of the people. And if that doesn't work and you still think you may have sleep apnea and you feel like you need medical management of it, of course, then you need a sleep study. But I feel a sleep study often isn't useful because it just tells you what you already know, which is that you don't sleep well. So better to just try solving the problems.
Thank you. That's helpful. Dr. Simmonds, is it normal to feel extra tired the day after physiotherapy for EDS and HSD patients? Or is it a sign that the treatment was too much and should be revisited according to our response?
Thanks very much, Lara. Thanks to the person who asked that question. That's quite a complicated question, really, and my other colleagues might want to chip in here. I mean, there are many reasons why people might feel tired the day after they see a physiotherapist or any other therapist or any other medical practitioner. It might have been the travelling in and out to the place. It might have been all about getting there and getting back. It might have been partly also to do with the emotions that are there when people come, and with their expectations, with their hopes and their dreams and their stresses and all of those things. And sometimes when you're able to release all of that, actually you can feel quite exhausted after that, so on an emotional level. And then from I suppose a physical perspective, you might feel tired afterwards because you have perhaps been, taken through a range of assessments and perhaps started on a program where there's been a lot of new learning as well, and that's exhausting. So it's not just the physical bit, it's actually the mental bit that's exhausting, and then there's the body itself. So you can see that I'm someone that likes to tease things out, which is why we've got the spider. I don't like to lump it all into one reason. There's often multiple reasons why people might feel tired. And so I think it's about, gauging that as it becomes a repeated thing. Obviously, all of us have talked about this partnership. It's important that you're communicating that rather than just saying, oh, that's no good because that's made me exhausted. It's actually saying, look, that was very tiring for me, trying to work out what it was. Maybe actually next time they don't need to come in. It might be an online session. It might have been too much. So those things need to be unpicked. Would others agree? You got anything else to add?
Yeah, I absolutely agree.
I agree. I agree with everything you said, Jane. And just when people have had a lot of tension in their body, the muscular tension and those holding patterns, I found that when you start to release that and we work on the breath and the relaxation, the mere unwinding of that tension can actually be quite exhausting, and people feel quite wiped out. But it is a temporary thing. You kind of have to go through that stage till your body kind of resets itself, and then you start to feel so much better. That's just my experience of it.
Thank you. And Jeannie, while we're with you, thinking about the reactions one feels when having therapies, how do you know when pain is okay to push through versus pain that is indicating damage is happening, so the movement should be stopped immediately? And we'll start with you, Jeannie, but I think that would be really helpful for everyone to chip in on if possible.
Yeah, it's a really tricky one, isn't it? Because pain is such a complex and individual thing for all of us. And as you know, I'm not into sort of no pain, no gain. I don't encourage people to push through pain. And the problem when we've been in chronic pain for such a long time is that for many of us, the pain is no longer a good indicator of how the tissue actually is. It doesn't mean that the tissue is damaged anymore because it's just become so sensitized to anything. I work very much on making people feel safe, because when people feel safe, so they come and see me, we do very gentle work to begin with to make them feel safe, because when people perceive that they feel safe, their pain can often start to go down. When people perceive danger, the pain signals are often going to go up. So I always say to people, you know, it's normal to feel pain when we're exercising. You're going to have muscle pain, especially if you haven't done things for a while. A level of pain is to be expected, especially after exercise. But if you're feeling that acute, horrible, nervy, horrible pain, the one that, you know, really takes your breath away, obviously we don't want to be pushing into that. That is a signal. New pain is a signal that something maybe isn't quite right. So you want to avoid that. I don't know if people agree with that.
Yeah, it'd be good to hear from others as well on that. Leslie?
Sure. So I try to teach patients to distinguish between appropriate pain and bad pain. So joint pain and ouchy pain is very seldom good. We generally want to avoid those. Some muscle fatigue or soreness, that's from exercise. And for people who have been able to exercise in the past, they may remember what it feels like to use a muscle appropriately, to have some healthy soreness when you do something that's new to you or you challenge yourself. Some trigger point management. If you're working on trigger points, there's a good kind of pain that should be like a good massage would be of, ooh, I know that's good for me. It feels good. So patients can learn often to distinguish between appropriate types of discomfort that are associated with good treatments and the bad ouchy things that we're trying to avoid. But it is very tricky, as Jeannie says.
Yeah. And Jane?
Yeah, no, and I'd agree with both Jeannie and Leslie with the things that they've said. And I think, you know, around that education, often we'll also say, you know, if people have been in chronic pain for a long time, then when they start to move again, you might find that the pain levels do rise a little bit because the system's sensitized. And what we generally say is, you know, if you're kind of, I know it's hard to score pain, but if you've kind of got a baseline level of, you know, 5 or 6 out of 10, we don't want it going up to 8, 9. We're usually happy, if the person's happy, that it might go up 1 or 2 points for a short amount of time. So we try to give them a kind of pain gauge a little bit to work with. So if it's gone up there, you've done too much, you know, that's really sensitized your system, and it's probably not a good idea.
Yeah, fantastic. Are we still with everyone? There we go. Okay, lovely. So we're coming up to the end of the session now. I want to thank you all so much. And I also want to take this moment to thank all of you here and members of the Allied Health Group in the consortium. When the pandemic hit, we turned to all of you to try and find ways that we could help our community who were stuck at home, unable to get to their physical therapists and the things that normally help them. And you all stepped up in your spare time, gave so generously, and gave so much free advice and time to our community. And so much gets done by you all behind the scenes that many don't see. And I just want to say a huge thank you to all 3 of you and all the members of the Allied Health Group for really helping us with that, and all of our community. We're very, very grateful to you. So thank you. And thank you for the great talks today.
Thank you.
Okay, it's time for that wiggle time, which I'm sure everyone here supports. We're actually going to take this time to learn more about Body Braid, one of our sponsors. So we're now going to hear from them.